Bismillahirrahmanirrahim. Today's topic is tumors of the middle ear. So we classify these tumor, primary tumor and secondary tumor. Primary tumors are benign and malignant. Benign malignant tumor is most common tumor is glomus tumor. Malignant tumors are carcinomas, sarcomas and rhabdomyosarcomas. So secondary tumors are from adjacent areas. They can involve the external or little meatus and middle ear. Then parotid tumor can involve middle ear, nasopharynx tumor can involve the middle ear. Metastatic from distant places from carcinoma bronchus, breast, kidney, thyroid, prostate and gastrointestinal tract can involve the middle ear. Carcinoma of the middle ear you can see in this picture, and squamous cell carcinoma is the most common tumor. Then in some cases adenoid cystic carcinoma can also be seen. So carcinoma of the middle ear, it is the commonest middle ear tumor usually seen in middle and old age, and 40 to 60 years of age. Females it is common, and it is really associated with chronic suppurative otitis media because of chronic irritation. And if patient presented with severe bleeding and granulations, so there is a strong suspicious of chronic carcinoma, squamous cell carcinoma of the middle ear in chronic discharging ear. So patient will immediately present with pain, and there is history of chronic ear discharge, and on examination there is granulations or polyp in the ear. So it means there is involvement of there is conversion of the normal epithelium into squamous malignant squamous cell carcinoma. So how does this tumor spread? Local spread and metastatic spread. Local spread, it can involve inner ear, it can involve external ear, it can destroy ossicles, facial nerve can be involved, jugular bulb if it is eroding the floor of the middle ear. If it is eroding the roof, then it can involve cranial cavity, brain, and it can involve last four cranial nerves, facial nerve, and in carotid canal it can penetrate into the internal carotid artery. So internal ear, it can involve labyrinth, vitreous bone, external bony meatus, intracranial adjacent structures that are parotid and TM joint can be involved by this disease. Metastasis through lymph node and venous drainage. So through lymph node it can involve first cervical lymph node, then parotid lymph nodes, and through blood it can uh, go into the distant sites. So glomus tumor are of, you can see in this picture, this is internal jugular vein, this is jugular bulb, this is internal carotid artery, and last four cranial nerve in between. So region, glomus bodies resemble carotid body. Carotid bodies are paragangliomas. So glomus body tumor is like the carotid body tumor, that is paraganglioma. Paraganglioma are the cells that surround the main vessels, and these are neurogenic in character. So polyhedral cells surrounding the blood sinusoid richly supplied by nerves. So this is the histopathology. So there are two types, jugular bulb tumor and glomus tympanicus seen over the promontory. So in jugular bulb there is multiple nerves, there is plexus of the nerves, and through this plexus this tumor arises. In promontory there is tympanic branch of the ninth cranial nerve, and this is the site of origin of glomus tympanicus. You can see this is from jugular bulb, glomus jugulaire, and it arises there and can come into the middle ear, and glomus tympanicus over the promontory. So etiology again, it is seen in middle-aged people, 40 to 50 years of age. In females it is common. It is usually non-encapsulated without capsule, and it is highly vascular tumor. So it is slow growing tumor, and it is locally invasive tumor. Because it is benign tumor, it is locally invasive tumor. Sheets of epithelioid cells, histopathology is that there are sheets of epithelioid cells with large nuclei, and cytoplasm will be granular. Blood sinusoids are seen without muscular port, so that's why it bleeds to touch. There is extensive network of the nerve. Types: glomus jugulare, glomus tympanicus. Spread: direct spread. Metastatic spread is very rare. Only in 4% of the cases metastatic spread is seen, and this is spread through lymphatic and venous. So direct spread, it can perforate tympanic membrane, can appear in the external auditory canal, it can involve inner ear, labyrinth, pectus. Through jugular foramen, it can involve last four cranial nerve and also the facial nerve. And through eustachian tube, it can involve the nasopharynx. So what are the clinical features? First, most important clinical feature is pulsatile tinnitus. Patient will complain of pulsatile tinnitus. There will be deafness. Deafness will usually be conductive in nature if there is no involvement of the inner ears. Then vertigo. But if there is involvement of the inner ear, patient will feel vertigo. And earache, because if it is penetrating the deep tissue, so there will be earache. These are the clinical features. So when you will examine the patient, red reflex can be seen through the tympanic membrane. In case of glomus jugulare, it is called rising sun, because it is below the involvement of the middle ear. From there is the involvement of the middle ear, so there will be uh, rising sun sign can be seen. So pulsatile bruit can be heard. Then polyp, if it is involving the external auditory canal, there will be polyp inside the external auditory canal that will lead to touch. Facial nerve paralysis and the last four cranial nerve paralysis can be seen if there is involvement of the intracranial cavity. So signs of involvement of the meninges can be seen. Then you will investigate it through, will be increased vinyl mandelic acid in the urine, that are the end products of epinephrine and norepinephrine. It is also seen in pheochromocytoma and carotid body tumors. So VMA is vinyl mandelic acid in the urine. So rising sun appearance is seen in glomus jugulare, because glomus jugulare can involve the middle ear inferiorly. So there is rising sun abnormality. So glomus jugulare, glomus tympanicus, whole tympanic membrane can be red in color. You can see in these pictures there is red bulging tympanic membrane, but it can be differentiated from acute suppurative otitis media. There will be no fever, pain will be less, and but you have to differentiate it with acute suppurative otitis media and secretory otitis media. So diagnosis will be made on history, clinical examination. You will have to differentiate it with secretory otitis media and from acute suppurative otitis media. So CT scan and MRI are very important investigations. Angiography, MRI, magnetic resonance angiography will show the supplying blood vessels to the tumors, and vinyl mandelic acid in the urine. These are the investigation. You can see tumor MRI. In the MRI you can see tumor, and this is the main blood vessels that is supplying the tumor. This is MRI contrast. Differential diagnosis: middle ear polyp, secretory otitis media, hematoma of the middle ear. In this you will see this type of appearance, and it can in glomus tumor you can also see this type of tympanic membrane. So how will you differentiate? There will be no history of traveling, pain will be less, but in cases of barotrauma, severe pain, and there is history of traveling. Hematoma of the middle ear, and acute suppurative titus media. In acute suppurative titus media, there will be fever, patient will be usually child. So you can differentiate it with other diseases. In cases of OME, there will be retraction or air bubble can be seen. So mainly treatment is surgical treatment, especially when the patient is young. So radiation is only given in inoperable cases when there is involvement of intracranial cavity, or if patient is very old, and because surgery is very extensive, surgery should be done in these cases. So prior to surgery, embolization is indicated. We will embolize the blood vessel supplying the tumor, and then combination of therapy can be given if there is some part has been left, if there is involvement of the intracranial cavity, so combination therapy is given. Nowadays stereotactic radiosurgery, but it is only done in old age patient who refused for surgery. So main treatment is surgical treatment that is given in this patient, surgical removal of the tumor, especially in young patients. Radiation is given in inoperable cases when there is involvement of intracranial cavity along with surgery. In cases of old age, when patient refuses for surgery, stereotactic radiosurgery can be done. This is the latest technique with minimal injury to the surrounding tissue. If there is involvement of intracranial cavity and patient is young, tumor is removed along with radiotherapy to the intracranial part of the tumor. Prior to surgery, embolization is done. Embolization of the main vessel that is supplying the tumor is done. So scenario, a woman 35 years of age presented to ENT department with progressive deafness and tinnitus in her right ear for the last 5 years. She noticed it during her first pregnancy. Now she is also developing same problem in her left ear. There is history of hearing loss in her mother. What is the most probable diagnosis? What are the differential diagnoses? What will be the tuning fork test, and how will you confirm your diagnosis? What is the treatment? This is the scenario of autosclerosis. So autosclerosis, serous otitis media, adhesive otitis media, tympanosclerosis, congenital fixation of stapes, dislocation of ossicles are the differential diagnosis. Rainey's test will be negative and the Weber will be lateralized to the affected ear. Medical treatment is given, sodium fluoride and hearing aids. Surgical treatment, says stepidotomy and with insertion of Teflon piston. So this scenario is a 35-year of glomus tumor. 35 years old female developed difficulty in swallowing and regurgitation of food through nose for the last 1 month. She was ignoring her left-sided deafness and pulsatile tinnitus for the last 1 year. So there is involvement of last 4 cranial nerve. That's why patient is feeling regurgitation and difficulty in swallowing due to involvement of the 10th and 9th cranial nerve. So most probable diagnosis is glomus tumor. What is the otoscopic findings and how will you manage the case? So glomus jugular involving the 9th and 10th cranial nerve. Rising sign appearance will be seen on otoscopy, or whole tympanic membrane can be red in color, or there may be polyp in the external auditory canal. So his diagnosis depends on history, clinical examination, investigations which will you order are PO2 audiogram showing conductive hearing loss, tympanogram can show type B graph. If there is fluid in the middle ear, that is the blood, and the CT MRI. CT will show tumor in the middle ear and involvement of the bone. MRI will show soft tissue involvement. Angiography, MRA, magnetic resonance angiography along with embolization can be done prior to surgery. So treatment is surgery, combined surgery and radiotherapy when there is inoperable tumor. Thank you.